cases. Good. Okay. We're now recording. We're looking at what happened during the pandemic, particularly at UMass Memorial with Janet Walder from the Share Union and Mike Pacinda, who's management at Memorial, at UMass Memorial at Worcester. They're going to share with us some details about their partnership, then get into what happened during the pandemic and maybe a bump in the road or a ravine. I don't think they hit a cliff. And then we're going to hear from Sylvia Everroad, who's the Chief Operating Officer at Kaiser Permanente's group in Southern California, and Denise Duncan, who's the president of the United Nurses Association of California Union of Healthcare Professionals. Unfortunately, we've had some internet challenges, so Denise will be sharing and engaged with us through a speakerphone, but we'll hang in there, and it seems like it will work. And then finishing out this important panel is Paul Clark from Penn State, and he will share with us some of the work that's going on in Penn State around partnership activity. So I've asked also us to conduct this in a roundtable. We're going to have the two sites, and then Paul makes some comments. The panel will have a chance to ask questions of each other or make some other comments they want, and then we'll throw it open to questions. And at that point, if we can flag through the reactions tab that you want to ask a question or make a comment. We have 55 minutes, and I'd like to ask Janet and Michael to join us. Thank you.
Okay, I'm going to share my screen, even though Mike and I are going to be very quick in giving the background. So let's see. Mike, you want to talk about the system first?
Yeah, sure. So UMass Memorial Medical Center, we're based in central Massachusetts, Worcester to be exact. We have two kind of, I guess, flagship campuses, if you will, in Worcester. The picture that you see here is the university campus. We are a clinical partner of the UMass Memorial Medical School. And collectively, we have, over 1,000 beds, and we're one of the largest employers in the region. We're a safety net provider. So many of the patients that we care for are on Medicare or uninsured, or some other type of government insurance. So that is us in a nutshell.
The Share Union represents about 150 different jobs, including techs, respiratory therapists, radiology techs, lots and lots of clerical, including billers and schedulers and secretaries, as well as nursing assistants, licensed practical nurses, mental health counselors. So lots of different jobs. And we built the union around the idea of having a say at work. It's never been structured as an adversarial kind of way. So this is really brief about our partnership. Mike, do you want to do this slide?
Yeah, right. So the, Share has, well, Janet knows this better than me, but been around for a while, I think since about 1997. And had done a really good job about negotiating in our contract, a lot of great job protections for its members. There's work security and income security provisions, but we got to a point where despite all that, we were still having some issues around employee engagement, and we wanted to kind of put our heads together and try to figure that piece of it out, how we can improve that. So we developed a partnership. We have really descriptive, important language in our contract that describes our partnership. And We've also kind of introduced the concept of bringing frontline caregivers into a process of looking at their workplaces and their departments and coming up with process improvements. We call them unit-based teams, and we have found that has really kind of promoted engagement and gave people, really changed how it felt for people to come to work. And then, of course, one of the other pillars is that we've created kind of like through that and hand in hand with, some other initiatives, a culture of kindness and respect.
I'll add that a huge footnote of credit to the Alliance and Kaiser Permanente partnership, labor management partnership. We have greedily ripped off many ideas from you guys and want to make sure you get the credit. So the unit-based teams are really modeled on the Kaiser Permanente labor management partnership model. I do want to add, though, that we've always had, since the beginning of the union, we haven't had a grievance procedure per se. We've had a problem-solving process that was really designed to be an alternative dispute resolution process. So it really, I believe, sort of created a green field for a partnership in a way that that has helped us a lot in building the partnership. So, Mike, I think our partnership was in a good place going into the pandemic. What do you think?
Yeah, no, I would agree. I think that, there was just a lot of trust, Janet, right? There was a lot of trust, there was a lot of respect. We kind of had that foundation. And then when we were really strained with COVID, we were able to kind of lean into that. And, we created this almost instantaneously, these daily briefings that, we'd have the share representatives on and just kind of explaining, updating them on COVID numbers. We came up with a process for PPE. I remember at the time, like N95s, were this really sort of like difficult thing to come by. So we had all processes around sterilizing them, and that in and of itself raised some issues. So there was just a lot of conversations, back and forth. It says we resolved hundreds of issues. I mean, that's accurate. I mean, daily, multiple issues coming up. We had a labor pool problem solving team that helped with redeployment issues, right? We had whole departments and sections of the hospital shutting down, and the support staff that would support these areas, right? Like, orthopedics, for example, or other elective surgeries and sort of, less critical areas. And then we had this work staff that we needed to kind of ramp up in other areas. And, I think Sharon and the hospital really worked well together to come up with a sort of a memorandum of agreement that set the ground rules about how we were going to handle these things, how we were going to, resolve issues. And I think the partnership was critical for our nimbleness in being able to respond to the crisis.
Yeah, it was definitely doing things you would never have imagined that we could have done, moving people from one job, hundreds of people from one job to another, and then figuring out all the problems and, people stuck in a COVID room for 8 hours without a break. Whoa, that can't happen. We need to fix that. So that kind of stuff. Yeah. And we did a bunch of education also of our members. We'd get the infection control people out there to meet with the members, or there was specific issues, and we did a lot of work around COVID vaccine education. So I would say in general, we feel like we did really well during the pandemic, but since we've been asked to talk about what was hard about it, we will do that. And of course, all of it was excruciatingly hard, right? I mean, members were scared out of their minds for doing the direct care with COVID. But from the partnership's point of view, I would say the hardest thing for us was the vaccine mandate. UMass Memorial came out with the mandate before CMS ruled on this. While there were a bunch of meetings where the union got to put in our point of view, it's not at all clear to me that point of view actually was of any relevance at all to the decision makers. So the process that was come up with that by the hospital appeared to us to be quite unilateral, and it completely ignored our disciplinary process in the contract. For example, there was a 2-week unpaid suspension as part of the process toward termination if you didn't get vaccinated. The contract limits unpaid suspensions to 3 days. How do we as the union explain this to our members? But the other thing that we really wanted to be talking about are these our members who work from home? We probably have 500 members who work from home. How, if they're going to be permanently at home, could they be exempted from the vaccine? But we were unable to sort of engage the employer on that. So from our point of view, it was quite a problematic process. I do want to say that there were pieces of it that worked quite well, and those were the pieces that were within the control of labor relations and HR. But for instance, the exemption process was a complete and total black box to us. Nobody understood how it worked. There was no way to contest a decision made by it. There was no appeal process. So that was really, really hard for us as a union. And our concern was that this was a sort of slippery slope moment where if this decision could be made unilaterally, what's the next thing that could be made that way? But Mike, let me.
Yeah, no, Janet, you and I have obviously talked about this a lot. I mean, kind of putting ourselves back in that time frame. There was a lot that we were kind of juggling as well, right? We did have this CMS guidance that we needed to implement, right? And if you kind of looked at the CMS definitions of what a remote worker was, it was really cramped. It was so narrow that it virtually excluded almost everybody. I mean, for example, it was like somebody that, there's almost no possibility at all that they would come on, not even for a meeting, not even for orientation, not for, employee health reasons. So we kind of, that's what we were sort of leaning on as we approach this. I think, I mean, I understand, kind of Janet's point, but with that said, we had several sessions, right, to kind of negotiate the effects of it, bargain over the effects of the decision. We did feel that this was something that was in, management's rights to make. We have an MOA. I think on this, Cher did a really good job about negotiating, protections for employees, members who were separated as a result of the mandate. For example, there's certain prerogatives to return to work, right? If an employee changed their mind, they would have priority to return to their position. So there were. I don't want to say like we entirely ignored Cher's concerns, but
no, I agree with that. And I think one of the things that we're trying to get out of it, I stole this from, I think Peter and Paul had given these out to us in the Healthcare Collaborative as a sort of structure for how do you know which decisions the labor management partnership are going to talk to each other about, and what level of input does the union have? And I would, so I think this is an area that we had not really talked about ahead of this moment, and I believe we have an agreed upon plan to try to have more of a thorough conversation. There's another example here that I believe comes from the Kaiser folks labor management partnership about like which topics get which level of input. And this is I mean, to me, this is the growth that we hope to have out of this experience, is to come up with something like that. We also are working hard now to make sure that the next phase of making work from home permanent is a sort of model process, so that the union doesn't have that slippery slope feeling of like this is the beginning of some new phase of decision-making model. So, and that's going quite well right now. So I really, to wrap us up, and you can chime in, Mike, but I feel like we had a bit of a problem. We're still doing good work. We're still, our partnership office is getting bigger. We're expanding unit-based teams. We just had a very successful joint experience of lobbying against the Mass General expansion into our region. And so things are going well. And I really think that there's an opportunity here to learn something from that vaccine experience.
All right. Mike, you had something else to say?
Yeah, no, I would, I agree with Janet. I think, that this could be the next phase. We haven't exactly kind of figured out, how we're going to sort of talk about this, who's got to be brought into the conversation. But this would be kind of the next frontier for us.
All right. So I appreciate the honesty about what went on. And, I think what you're saying is, maybe added on to the topic of today is not just strengthening, but how to prepare. It sounds like what Janet, you're raising is how to prepare for a potential conflict, and maybe using that decision-making matrix helps to identify the expectations people have for various areas of work. So we're going to shift gears to the Kaiser Permanente partnership with Sylvia and Denise. A lot of people know about the partnership and also know about the potential strike that almost happened last fall. So I think we'll learn a lot from them as well as from you at Mass. So Sylvia and Denise by phone, let's hear from you.
All right. Well, I think we'll take a little bit different tactic. I think many people know that Kaiser Permanente has a national footprint. We're in 8 markets. Denise and I are from the Southern California market. It is our largest market. We serve 4.7 million members. We have 13 medical centers with 16 hospitals. That doesn't really include all our affiliated hospitals. So many of those. We operate ambulatory services out of 260 medical office buildings across Southern California. And I'm sharing just to give you an idea of what our system looks like. We have 22 labor management contracts in Southern California. The Alliance contract covers about 27,000 staff, not quite half of all our employees. We have about 80,000 employees. We have 2 smaller traditional unions that are not labor management, and that's about 3,500 employees. We do also have a medical school that's relatively new in Southern California here in Pasadena. We have a school of anesthesia for nurses. We have over 1,400 UBTs, so we're big on UBTs. We really think that is the path for labor management partnership. I think maybe at this point, let me turn it over to you, to Denise, to talk a little bit about labor's perspective about why we entered LMP, and then I'll talk about management.
Okay, thank you. I apologize for my technical difficulties here on my end. First of all, let me just tell you, UNAC UHCP is part of the Alliance. As many of you know, we broke away from the coalition in 2018. So Kaiser Permanente now has 2 labor management partnerships, one with the coalition and one with the Alliance. The Alliance in Southern California is quite vast, represents a large percentage of RNs and healthcare professionals, as well as other contributing workers. Our Alliance has about 50,000 members, maybe a little more, and it is made up of 10 different unions from Hawaii to Georgia, the Northwest to Southern California. So when we bargain for that group as a whole. The interesting thing about this past negotiations, I think, would be to compare it to the original partnership negotiations that occurred in 2000. After a very rough time in the early to mid 90s, the partnership was formed at Kaiser Permanente with the coalition, and we came to an agreement on our partnership in 1997 with Bart, and we bargained our first contract in 2000. Most of us felt it was a very, very rich experience, that the contract really set a pathway for performance, improve initiatives. There were things on both sides that could improve the company's competitive edge, as well as the union experience for members. We were very happy with that contract. And by 2010, we saw ourselves really hitting our stride. We collaborated on change, education, innovation. We saved money. Our unit-based teams were stronger than ever. And it will be interesting to compare with the University of Massachusetts regarding some of their learnings down the road. But we found that our members understood budgets, could put Excel spreadsheets together, and they developed skills that were new for healthcare workers. And so we're very proud of that work. Just as struggle and strife came out of the early years, we found ourselves back in this situation again last year because of the competitive edge that people feel they need to have in healthcare, the constant changing. Kaiser Permanente is not for profit. There are many challenges in how Kaiser cares for patients based on what people want to offer in the community. As for those of you that follow Becker's and Modern Health, you know it is constantly changing the things that are going on. We found ourselves in a situation back in 2016 where we felt that we were losing many of our best LNP partners due to retirements, of those that have the history of what went on in the early years, that had helped to develop relationships and toolkits, pathways to performance. All of the things that we were using to be the guide for our work was slipping away. People were being hired in. There was a lack of training, a lack of investment in new hires coming into the system. I personally felt that people were being hired and they were bringing part of their old job into Kaiser Permanente, and that we collectively, not just the employer, had sort of missed our focus a little bit. We had stopped thinking about how we needed to shore up and constantly develop this strategy to sustain what we were 20 years into the making. There were many people that felt that the labor, that our LNP had become nothing more than a labor relations strategy, that we were no longer in a culture of partnership, and we were struggling. So, of course, then it was time to bargain. We had, I think Sylvia's going to talk to you about COVID. We had some of our brightest hours, some of our best hours of collaboration during COVID, but we also had many of the same challenges and concerns. It was tough. It was some of the hardest work that we did collectively, and I wonder if what we would have been able to do and accomplish if we hadn't had partnership. Sylvia?
Well, I'll backtrack. Thanks, Denise. I'll backtrack just a little bit about management's perspective as far as why we found the LNP desirable option for us. I think it was really important for us to become aligned with our goals and objectives, because we wanted to be able to have honest, transparent conversations and be able to move initiatives quickly forward. And we have been able to do that. And Denise has been an incredible partner, actually. We've done some very innovative things, but it was very important for us as well to have labor peace. So in the late 80s, early 1990s, we were having ongoing rolling strikes. So for us, from a management perspective, it was important to have in our contracts no strike language, no sympathy strike language. We really did not want to cover the cost of a strike. We really didn't want to have patient services disrupted. We wanted to make sure that our members felt comfortable at our medical centers and could depend on us for ongoing care. So from our perspective, that was really important. And we thought that labor management partnership was really the way to accomplish that. So I think we came at it from a little bit different perspective, but it's been a very positive. Skipping a little bit to COVID, I would agree with Denise. I think that really helped unite us again. Denise was talking about in 2016, we had a major turnover. We offered changes in our benefit. A lot of people decided to take the benefit retirement package, and we had a 26% turnover in our managers in the medical group. And so Denise is absolutely right. We also had our labor partners turnover, that we had a lot of new people who didn't have the history with LMP. They didn't understand how we arrived where we did. And so that created a situation where we needed to refresh. But with COVID, I think it really gave us a single point of focus, right? And we really worked well together. We had a decrease in our grievances. I heard that from Massachusetts folks. We were very flexible with staffing, with incentives, with moving people around. We had rapid decision making. We had constant communication. We really relied heavily actually on Denise's team to get messages out to staff, because they would respond to email blasts and text message blasts. And so that was very helpful. That was a big learning. I think that, you know, in partnership, we really had made fast decisions. We had our transparent thinking, and we really stripped away all the distractions. So did we have challenges? Yes, we had the same challenges with the PPE that you talked about in the sterilization. We took a trip to take a look at that, but then eventually we got enough supply. We had similar issues with remote workers. We decided to look at remote workers from two different perspectives, like administrative remote workers we handled differently than patient-facing remote workers, right? Because, and that really seemed to help us, because managers really wanted the opportunity to bring paid staff back if they needed to, in case of emergent operation needs. We also struggled with the vaccine, but California had a mandate, the state of California, so that helped us. It didn't help with the decision individuals had to make about having a vaccine, but at least it set the foundation for decision making. And we did use strict definitions for exemptions. And we were talking before the podcast started really about, we decided on a centralized process for exemptions and whatnot, so that could be really an objective assessment and take it out of the hands of management and of the frontline physician. And I think that really served us very well. So we had a lot of challenges, but I think, as Denise was saying, we're coming up to 25 years of partnership. We're getting ready to celebrate 25 years. And that did kick in and get us, I think, over some of our initial issues. But it wasn't perfect going. And Denise, I know you're going to talk a little bit about the strike and the threat of strike. But a lot of what happened, I'll just kick it off a little bit, was we did have a lot of new leaders. And that does make a difference. So we had a new management labor relation leader. We had new HR leader, all new to the organization, all new to LMP concepts. And I think that contributed, along with the stress of our physicians and our staff, not the perfect, kind of the perfect storm for labor negotiations. Let's put it this way. People were exhausted. We've been through a lot. We had new folks, and now we're into labor negotiations. Denise, you want to take it from there?
Sure, thank you. So, because we began our bargaining in 2021, we actually started later than we normally would, but the unions felt strongly they did not want to push it back into 2022. There was a lot of ground we had to build up, and a lot of concerns about who are all of these new people sitting at the national table that we've never seen before. You know, I jokingly said at a LIRA conference several years ago that people that work in partnership actually have their own speak. We say things like, how might we, help me understand? We try to avoid any or adversarial conversations or comments. And we found ourselves in a situation where people didn't even understand how to frame the conversation. And it was part and parcel due to the newness and the lack of education and onboarding. We had a lot of angry members last year. COVID, not everybody wanted to work in a new space. People were working short. We didn't have the amount of resources we normally did. We've talked about the PPE challenges early on. Our members lost faith in the CDC, felt like that the rules of the game were constantly changing. And for the first time in a very long time, we had a huge percentage of members in our alliance calling for a strike. Our members felt that the partnership was being dismissed, not invested in. There were too many grievances that were popping up, adversarial relationships, reporting nurses to the Board of Registered Nursing or pharmacists to the pharmacy board. Those are just examples of how people thought that our culture was shifting. So when it became apparent that we were going to have to take a more traditional approach to what was sitting on the table, our members were ready to strike. 86% of our Kaiser Permanente UNAC members, those in the union that I represent, showed up to vote, and 96% of those that voted to strike. Those are the largest numbers we'd ever had. UNAC also paused our partnership for about 6 to 7 months because we felt strongly we needed to get back on track and have crucial conversations about how we re-engage, how do we start over. We ultimately knew that if we went on strike, that would be the demise of our partnership. But I would say that ultimately what brought us back together in those final hours of negotiations was a commitment across the board from management and labor to really invest in a process. Although we knew it would not be a quick fix, it would take a couple of years with intense engagement, education, each of us holding each other accountable. Labor, we fell down as well. There's no question that we were struggling and we'd had turnover, as Sylvia said, and we'd lost ground. But now we're committed. I think we're working to do our work, and Sylvia can share with you some of the things that we're talking about doing. We do think partnership probably, our trainings need to be more streamlined, more efficient. We need to refine our processes. We don't have to, we want to partner in the way that we've traditionally agreed to partner, but maybe these things need to be updated. And so we're working in that capacity now. Sylvia?
So I know we're like at time, so I'll be brief. I think the big takeaway here is the recommitment, right? We have publicly and personally recommitted, and we have started talking about interest-based strategies and getting aligned. So we can get aligned on growing membership, skill building, workplace safety, attendance, scope of practice, customer service, wellness for our staff, our physicians. These are win-wins for management, labor, staff, everybody. So focusing again on what made the partnership strong, what made Kaiser Permanente strong in Southern California really was a joint effort. We're better together than we are apart. And then starting to build back the personal and professional relationships. And as we talked about the turnover, it's natural turnover actually in our organization. It's not anything that's strange or different, but it's just a natural turnover that we're experiencing. And so now we have to develop new relationships, because with the new relationships then comes trust. When you know your partner, you have respect for them, you know that you can hold them accountable, and the decision making moves along a lot easier. So we've recommitted to that, to refreshing the LMP, bringing it up to speed post-COVID, and really getting to work on it. And I'll leave it at that, because I know we want some discussion.
Yeah, I feel frustrated that this discussion probably deserved 2 hours or 2.5 hours of detail. I mean, the one other detail that I'll share is that at UMass Memorial, one of the turnovers is the head of labor relations and human resources has just retired, and that's a similar situation of who is that person, who's going to replace that person, and to what extent will leadership follow the partnership values. Paul, would you like to share with us some of the observations you've made from the standpoint of Penn State's healthcare partnership initiative?
Yeah.
Oh, you're now on mute.
And then I muted myself.
Yeah.
Okay.
Yeah.
I'm going to talk for a few minutes about an effort here at Penn State that falls squarely under the heading of this session, which is strengthening healthcare partnerships in trying times. About 2 years ago, the School of Labor and Employment Relations at Penn State undertook an initiative called the Healthcare Labor Management Partnership Initiative, or the HPI. And let me talk about that just briefly. The initiative was created by 3 of us here at Penn State, 3 of us who were here at the time. Peter Lazes, who is perhaps the leading authority on labor management partnerships in healthcare in the U.S., was a visiting professor here, or is a visiting professor at our program. Zach Zopris was at the time a member of our school's labor education staff, and he was formerly an SEIU statewide union officer and staff member who really championed partnerships in that role. I should note that Zach subsequently returned to SEIU to continue advocating for partnerships. And I was the third person. I have been interested in doing research on partnerships for almost 2 decades now. And Peter and Zach, feel free to jump in here since you were a part of this. I believe this initiative is one of the only, or perhaps the only, university initiative right now that's systematically working with partnerships to help them be better and stronger, and the only initiative that's advocating for new partnerships in healthcare. Now, prior to COVID, the 3 of us believed that the very serious challenges facing American healthcare could really only be adequately addressed with the significant involvement of healthcare employees who every day provide hands-on care, who play other important roles in our healthcare system. And we believe the uneven and in many cases suboptimal response to COVID of healthcare facilities around the country powerfully proved this point. Where partnerships were in place and workers had a voice, I think it's pretty clear that things work better, not perfectly, but better. In our view, labor management partnerships are the best vehicle for providing healthcare workers the kind of voice they should have in healthcare workplaces. But we're also aware, and have been aware, that despite the contributions of healthcare partnerships around the country, they are in fact few and far between. Beyond Kaiser Permanente's well-known partnership, there really are only a handful of active partnerships. And these partnerships face very significant challenges in playing the role they were created to play. And because of their relatively small numbers, they sometimes feel isolated and have minimal contact with other partnerships. So the goal of our HPI was to provide a mechanism for partnership leaders including management partnership leaders, union partnership leaders and activists, and partnership facilitators to come together to talk with others in these roles about the challenges they faced and the strategies and responses that they developed to address these challenges. In short, the objective was to bring folks together to learn from one another and develop ongoing supportive relationships that could strengthen these initiatives. Our second initiative was and is to serve as an advocate for partnerships in healthcare and promote such initiatives by sharing basic information and helping healthcare institutions who are interested in partnership take the first steps in that direction. So to get this initiative underway, we spoke with union management and facilitator consultants at several ongoing partnerships, the ones that we are aware of. I should note that we didn't include Kaiser Permanente, as their partnership is clearly well-established and well-resourced. It's at a size and a complexity that makes it somewhat unique. But we talked with the other partnerships we were aware of, and these conversations convinced us that there was real interest in these partnerships and the participants in these partnerships in coming together to learn more about one another's experiences. So we decided to move forward with a program we named the Healthcare Partnership Learning Collaborative. The key idea was to meet periodically in a structured and systematic way to exchange ideas, discuss challenges, discuss accomplishments. And a key decision going forward was this would involve all of the participants in the partnerships, union management and facilitators. So the initiative developed into a 5-session program conducted from May, I believe, 2021 to October 2021. We invited participants from 7 or so existing partnerships, and 5 of those partnerships ended up participating. This included UMass, the UMass Medical Center, the Medical Center at the University of Vermont, the partnership at the LA County Department of Health, Allegheny General Hospital in Pittsburgh's partnership, and an emerging effort at Penn State's Medical Center in Hershey to start a partnership. The earliest sessions ask each partnership to make presentations about how their partnerships came about, their goals, its present form, its accomplishments, and the challenges they faced. We then organized breakout sessions so that the participants could talk amongst themselves in smaller groups about these issues. As I said, the sessions were all held virtually during COVID and about 4 to 6 weeks apart. Between each session, participants were given some homework to prepare for the next session. Attendance held up pretty well, with generally between 40 and 50 participants from the 5 or so groups attending most sessions. Subsequent sessions delved deeper into the goals of partnerships, the extent to which their efforts were aligning with the goals. We focused on the kind of training necessary to prepare participants, the impact of partnership on the larger labor relations situations in the facilities, methods to improve the relationship, and things that could be done to sustain partnership in the long term. Occasionally, we would have the individual parties meet together to discuss perhaps more candidly their concerns. So management from the 5 participants, the 5 partnerships would meet together sometimes, the labor representatives and the facilitators. We also would occasionally bring in speakers or experts from the outside, and Kaiser came in at one point to discuss, I believe, to discuss how they dealt with the issue of the difficult role of middle managers, but maybe Peter or Zach could correct me on that. We gathered feedback on the 5 sessions. It was very positive. Participants particularly found the opportunity to share and learn with each other to be very useful. Earlier this spring, we asked participants if they were interested in occasional follow-up sessions. They said they were. We organized a session in March 2022 and brought folks back together. I think, again, that people found that very useful. So going forward, the plan is to, based on the wishes of the groups involved, the plan is to come together on a regular basis, maybe 2 to 3 times a year, to hold these collaborative learning sessions. And we'll continue that in the months and the years ahead. I will say that we haven't made a great deal of progress on our second goal, which is promoting new partnerships. We're not sure how to go about this, since it's difficult to find out if there are parties out there who are interested in partnership. But if parties are interested, we're willing to hold a series of sessions about how you start a partnership, how you structure it, et cetera. And I'll close on one promising development, and that is the new initiative by the U.S. Department of Labor that we just heard about yesterday, that is promoting partnerships, including healthcare partnerships. And we very much hope that our initiative can plug into that and be a resource for any groups out there who are interested in engaging in partnership. So with that, I'll turn it back over to Peter.
Thank you, Paul. Unfortunately, we have 11 minutes left. There are 22 of us, I think, on this session. I want to throw it open for questions now, either from the group that presented or to each other, or others who might want to ask for some additional information or perspectives that you hadn't heard talked about yet. So,
Peter, I sort of had a follow-up question for Sylvia
Sure.
and Denise. You know, it sounded like during COVID there was a lot of like overlapping, you know, similar struggles and issues we were dealing with. I'm wondering, did Kaiser make a decision like UMass did to intentionally not engage in layoffs or furloughs? And depending on what that answer is, if it's no, like how did you sort of like go about that?
The way I would answer that is because of the exclusive relationship the medical group has with the hospital. So I represent the ambulatory medical group, the physician piece. We actually shut down our ambulatory services to a great extent and redeployed our staff to the hospital, the emergency room, to support the COVID patients in the hospital.
Mm-hmm.
And so we needed everyone hands on deck.
Right.
We also did, we centralized like the COVID testing and the vaccinations. We did it not on our campuses. We actually went off campus to some community spots. And so we had to relocate people to those areas. So we kind of redeployed everyone to the hot spots, and because we had a lot of COVID leaves, medical leaves, and we had people out sick because we were hit so hard in Southern California. It never occurred to us to furlough. We didn't have that option. Actually, we needed everyone.
Right.
We redeployed our physicians as well. to the hospital. So
Mhm, mhm.
that's kind of the scenario. Does that answer your question?
Yeah, no, definitely. It sounds like a very similar experience to what we had. Thanks, Sylvia.
Yeah, you're welcome. I'm curious, we found that a lot of people, if you're experiencing this, are deciding not to work in the healthcare profession anymore. And so our vacancy rate is a little bit higher than normal because people are choosing not to come back to the health professions. Are you experiencing that as well?
Absolutely. Yep, we definitely are, and we're actually, working in many cases in partnership with Share on recruiting efforts. We held a Share Friends and Family recruiting event in January, where members can invite, well, their friends, their family, nephews to come into this event where we had a whole bunch of our talent acquisition folks, and it was just, kind of an introduction on the many jobs that were available. At UMass, we did something similar specific to radiology. So yeah, no, we're struggling with that as well, Sylvia. We're employing a lot of travelers right now. We're trying to get those numbers down. We've offered sign-on bonuses, referral bonuses, shift incentives. I mean, we've really kind of are using a lot of tools to try to fill shifts.
I like that idea, friends and family. I'm going to take that one. Can I have that one? That's a good
You
one.
got it.
Absolutely. Yeah, I don't know.
Do you want to comment a little about what's going on in Pennsylvania around recruitment and retention that you talked about a little about yesterday, but maybe comment about today?
Is that to me? Is on
Yes.
Pennsylvania? Yeah. Well, I would echo the friends and family. I think I was starting a version of that, and then Jan and I were talking, and I built in they did Zoom interviews. So we've been doing social media and texting, like, do you know someone who wants to be a CNA, for example? And we're finding that gets us some folks that are serious about wanting to do that. And then hearing what Janet and Mike did there at one place, we did do a Zoom interview. Well, the employer hired folks on the spot. So
Great.
yeah, that's
We're kind of back to the late 70s, early 80s job fairs, hiring events. We haven't done that for 30 years, 40 years, but we're doing exactly the same thing, it sounds like.
Yeah, and staff are just so toasted, so tired, so exhausted, working short, picking up extra. It's tough. We're going into contract negotiations, and I'm thinking of your story, Denise and Sylvia, as a cautionary tale, because members are pretty stressed and stretched to the max.
Some other questions or comments? We still have some time.
Well, I have one if I'm not.
Sure.
Yeah. I'm interested in the question of what building relationships across union and management looks like. I think in Share with management, we have a sort of new manager arrives, go to lunch with them, get coffee, have a Zoom meeting, and there doesn't have to be a topic. There just is, we just need to know each other. But we don't have a more formal, what does relationship building across union and management look like? It does feel like it's an art, and it's two people who need to know each other, trying to become friendly, if not necessarily friends, but to establish enough of a working relationship that when there's a problem, you pick up the phone and you're calling someone and someone you enjoy working with, and you can solve it. But I'm interested to know whether you guys have sort of formalized that process at all, or figured out how to do it.
Well, this is Denise. First of all, I have to say that a good partnership's not a 9-to-5 job. If my management partner, and this played out over and over again during the COVID crisis, if my management partner needs to talk to me about a redeployment or an area that is critically short on staff, and that happens at 6 a.m. on a Saturday morning, and he or she calls, I'm going to pick up the phone, because these are partners that don't call you at 6 a.m. every time you turn around. And on the other, I want to be able to have that same privilege of somebody picking up my call or one of our affiliate leaders call, or one of my directors that might call. The same thing. It has to be a collaborative understanding that when someone reaches out to you, you probably need to engage, because they just don't call all the time. When we came back together this spring, UNAC sponsored an open house in the evening with all of our high-level leaders in Southern California. Sylvia was there. We had the HR, labor relations leaders. We had Julie Miller-Phipps, who is our on the health plan side, our leader. We had everyone there. They came and they support. These are people that have history and they have the same interests in really shoring up this 25 years of work, that fundamentally believe it down in their core and realize that it's challenging. We have a lot of new players, but are committed to getting it back on track. Sylvia has talked to us about having offsite retreats and getting those back up again, and bringing people together in a space where we can do that safely, to really have those opportunities to tell our stories and get to know each other. We got so, labor unions are frequently criticized for bogging down a process, obstructing a process. You can't make change because the union won't move forward. That's not been our story. Our story has been like the Target retail clinic, where we banged out an agreement in 2 hours. And there are many, many others. We had already embarked on virtual work in 2018 when we were bargaining that national agreement. We had all that work and those commitments and those understandings in place, which made it very, not easy, but made it easier to say, yeah, we've already committed to that. So now that we're in a COVID crisis and we need to do virtual work, and we need to redeploy people, this is how we can do it. And so I think it's an ongoing thing. I will say I'm so happy to hear that there are bigger and bigger conversations regarding a national partnership and how people in healthcare can come together. But I'm not naive. I know that not everyone can work in a partnership model. It takes a lot of commitments to do a lot of things, think out of the box, build relationships. It's not easy for everyone. And so it'll be interesting to see how that plays out. I'm a big advocate of partnership. I've worked without it. I've worked with it. I fundamentally believe that it's the best model to do the work in healthcare. Recognize the voices on the front line that do the work, that care for the patients, and keep the system going. It's just too valuable not to have. I hope that answers your question.
We're tight for time, but Bob McCursey, you had a question or a comment to make before we close out this session?
Yeah, I have a comment. I think it's a terrific session, and I think what it illustrates is how a partnership is a high wire act. I mean, it takes incredible dedication and re-engagement, et cetera. And I think, as Paul mentioned, it's really great that the Department of Labor is going to become a center. But, I've watched, participated at different times in the Kaiser, and it's terrific that 25 years is now in front of us. I guess the question is how to penetrate the employers in the healthcare industry. So they should be at a session like this, being interested in what the payoff is for a partnership. If we want, in a sense, and that's terrific what Penn State is doing, how, in a sense, to get more traction in this important industry. So we don't have a 25-year story and only a few emulating it. In a sense, we got to get up. We got to get a different traction going.
Well, I appreciate your comment and observation, Bob. I would say that maybe we're at a tipping point. I mean, I think that one of the things that the pandemic has done has demonstrated how broken our healthcare system is in terms of service and in terms of working conditions that have caused, so many people to leave healthcare that we're not planning to leave it. So the question is, how can we raise with management the opportunity here to correct these situations? And maybe the Department of Labor can step out. I'll just end with the fact that during the Clinton administration, Robert Reich and Clinton held a national forum. I'm not too sure. Steve, you might have been there. I was there. There were a number of other people. There was a big push from the Department of Labor, not just to collect stories, but to provide resources to support partnership activities. And maybe we have with Marty and the Department of Labor the kind of vision that goes beyond storytelling, but really talks about having a national forum to put this really front and center to the public. The public now, I mean, part of what's now, I think, unique is the public now knows how broken our system is. It's not just us in healthcare. And the question, Bob, is an important one. How can we take advantage of this opportunity? Steve, did you want to comment on this just before we close?
Yeah, that was in the late '90s. A guy named Marty Manley headed up a whole division of collaboration and sponsored a lot of research in this area. So, yeah, it's back to the future, Pete.
I want to thank Janet, Mike, Sylvia, Denise, and Paul for the session, as well as the 18 or 21 of you who joined us. And I would just say that I saw a chat from Janet. Some of the UBT and partnership activity is in collective bargaining arrangements, but also a sidebar agreements at places like Maimonides Medical Center. There are other places that during the course of the contract, there's a need to clarify the relationship and make sure that there are resources available. Thank you all for joining us. Have a nice afternoon.
Okay. Thank you.
Thank you. It was a pleasure.
Yes,
Bye-bye.
thanks for
All
having
right,
us.
thank you.
Thanks, everyone.